Hey everyone, welcome back to Static Cardiology here on EMTV. I'll be giving you an ECG rhythm and a scenario. On the bottom of the screen you'll see a timer for 1 minute and 30 seconds. This time closely resembles the average amount of time you'll want to be spending on each card during an actual National Registry exam. When the time is up, we'll go over the rhythm and I'll give you my treatment. Enjoy the card and good luck.
3, 2, 1.
Now this rhythm may have been very confusing, especially if you didn't know to look for a certain clue that would have given it away immediately. Let's go ahead and take a look at lead 2 in a little bit closer detail. Now the first thing I like to do when I'm identifying any rhythm is to count the rate. Now you do have to realize that when you're looking at a 12 lead ECG, you're actually looking at a 10-second strip. So if your math is really good, you can simply count all of the R waves here and multiply by 6. But as most of us, including myself, feel much more comfortable multiplying by 10, we're going to make this into a 6-second strip. In order to do that, I'm going to take 2 large lead groupings, which are 2.5 seconds each, and then add 5 big boxes. This will be my 6-second strip. Then I'll count my R waves. I'm counting 6 R waves, which makes this a rate of approximately 60 BPM. The next thing I'll do is check for regularity. My distance between R waves here, or my R to R interval, seems fairly consistent. When measuring my QRS complex though, it appears slightly wide. Now if you were unable to initially identify this rhythm, we're not going to get the best information looking at this lead view. Let's go ahead and pull back and I'll show you those small little clues that I had mentioned earlier that would make this rhythm very easy to recognize. If we pull back here, you'll notice the presence of these small triangles at the top of the 12 lead. Now, if an EKG machine is good at one thing, it's recognizing the presence of artificial pacemakers. So what you're seeing here are actually pacer spikes. There are pacer spikes present for P waves and QRS complexes, meaning that this is an AV pacer. Now you may be thinking to yourself, is this a pacer that's malfunctioning because I'm only seeing a single spike present for certain complexes? This pacemaker is actually functioning normally. It's designed though to allow a certain level of inhibition, meaning that if the pacer detects a normal activation of the native pacer site in the heart, it will not attempt to pace over that. As we can see here, there is a single complex present for the QRS complex, meaning that this patient requires pacing on the ventricle. But there's a very small P wave present here without a pacer spike. In this instance, the AV pacer allowed normal SA node conduction and then simply assisted the ventricular conduction. Now that we've kind of got an idea of what this rhythm is, let's go ahead and take a look at each lead grouping to see if there's anything more serious going on. In my anterior lead grouping, leads V1, V2, V3, and V4, I'm seeing mostly ventricular pacing here. That pacer spike is fairly obvious, and you can see the native P wave that this patient created on their own without a pacer spike preceding it. So their implanted pacemaker was inhibited during this normal conduction. Let's go ahead and take a look at the inferior leads next. In my inferior leads, leads 2, 3, and AVF, I can more clearly see an atrial pacer spike than I can a ventricular pacer spike. However, if we remember from the bigger picture, the entire EKG view, I know that there's a ventricular pacer spike present here. I just cannot see it clearly in this particular view. This is an example of why it's important to look over the 12 lead in its entirety before you make your diagnosis. Let's look at the lateral leads next. My lateral leads, leads 1, AVL, V5, and V6, are showing a mix of AV pacer inhibition as well as a fully paced dual chamber rhythm. Because of this, my diagnosis of this rhythm is going to be an AV pacer, sometimes called an AV sequential pacer or a dual chambered pacer. Now, let's go ahead and take a look at the scenario. You were dispatched to a local church for a 75-year-old female complaining of chest pain. Upon arrival, your patient reports that her pain began 1 hour ago and has continued to get worse. She describes the pain as a sharp pressure that radiates into her back and jaw. She is alert and oriented and denies any shortness of breath or dizziness. Physical exam reveals lower extremity edema bilaterally, clear lung sounds, and diaphoretic skin. You cannot reproduce the chest pain with palpation, and she denies any recent trauma. Your partner obtains the following vital signs: blood pressure 158/92, pulse 63, respirations 19, SpO2 98% on room air, and a blood sugar of 133. You attach the monitor and obtain the ECG above. In order to be successful in static cardiology, not only do you have to identify the rhythm, but you have to determine whether or not it is stable or unstable, and then follow the correct treatment algorithm. For instability criteria, I use the acronym CHAD. And this, of course, stands for cardiac insufficiency, hypotension, alteration in mental status, and dyspnea. Based on my patient's current presentation as well as her vital signs, my final diagnosis for static cardiology is going to be a stable AV-paced rhythm. Now, let's go ahead and move on to the treatment. Just like with all my other cards, I'll begin treatment by regurgitating the mantra: Scene Safe, BSI, IV O2 monitor. Now, there was a very important part of the scenario that would lead me more down an ACS pathway versus a typical pain control pathway, and that was the reproducibility of symptoms. Palpation of the chest revealed that this patient's chest pain was not reproducible. This is important because it's very unlikely that you'll be able to reproduce cardiac chest pain. Musculoskeletal chest pain, such as costochondritis, will usually get worse if you palpate it. Because this patient's pain did not change with palpation, I'm going to suspect pain of a cardiac origin. To treat that, I'll begin by administering nitroglycerin. 0.4 milligrams given sublingually as a tablet or as a spray every 5 minutes to a maximum dose of 1.2 milligrams. The next medication I'll administer is aspirin, 162 to 324 milligrams given by mouth. This usually works out to 2 to 4 tabs of baby aspirin, and this is chewed by the patient. Chewing the aspirin allows a much more rapid onset. And be aware, the aspirin isn't here to treat pain. The aspirin is actually to prevent platelets from sticking together and potentially making a coronary thrombus worse. If the pain is still uncontrolled or unrelieved with nitroglycerin, I'll then consider administering an opioid, such as morphine, given 2 to 4 milligrams IV, or fentanyl, given 25 to 100 micrograms IV. And finally, rapid transport. And that's it. If you enjoyed this card, please make sure to head over to my channel for more. And while you're there, check out my other playlists like Static Pharmacology. Thank you so much again for liking and supporting these videos and supporting my channel. Until I see you next time, stay safe, keep washing your hands, and have a good rest of your night.